going to move on to session 2. This is a session that I'm really looking forward. A session where we're going to hear from CEOs, Chief Wellness Officer, and the Chief Nurse Executive. And we wanted to hear from those leaders that come from different healthcare systems, from different background, different profession, and hear how they implemented strategies during the COVID-19 and address clinician well-being. So we have 2 pairs that we've invited for this session. And so we're going to start with Dr. Nevin and Dr. Farley from ChristianaCare. Dr. Nevin is President and CEO of ChristianaCare since 2015. She actually joined.
Good morning and good afternoon. I think I lost Dr. Carry on there, but I'm hoping that folks can hear me. I'll go ahead and get started. I'm Dr. Janice Nevin. I'm the President and CEO of ChristianaCare, and it really is a privilege to be part of this discussion and to share the platform with Dr. Heather Farley, who is ChristianaCare's Chief Wellness Officer, as well as our colleagues from Emory. Next slide. So just for those of you who may not be familiar with ChristianaCare, we're a large community-based academic health system serving the people of Delaware, Maryland, Pennsylvania, and New Jersey. We frame our mission statement as the ChristianaCare way. It's our promise to those we serve. We serve our neighbors as respectful, expert, caring partners in their health. We do this by creating innovative, effective, affordable systems of care that our neighbors value. As I often say, what we do is simple yet profound. We take care of people. Next slide. Dr. Carry-on talked about the importance of values, and we are a deeply values-driven organization, and it really begins with our values statement. We serve together, guided by our values of love and excellence. Yes, we are a health system that talks about love in healthcare, and as we have learned, and we firmly believe that when we lead with love, excellence is inevitable and equity is achievable. These values really have been foundational in creating our culture. We know that personal resilience is important, but for organizations to not only survive but thrive in times of uncertainty and challenge, it's that organizational resilience that really matters. And that very much means that the people are connected to the values, those core values, and behaving in a way that demonstrates those values each and every day. So in March, like most health systems throughout the nation, we put months of preparation for COVID-19 into action. And I was so grateful that we had these values because they really gave us a place really to ground our work. We've treated more than 1,400 COVID patients in our hospitals at this point, and thousands in our outpatient and virtual care practices. And while the good news is that the vast majority of these patients have recovered, we've also experienced the profound grief of the families of those who have fallen to this disease. And the isolation, fear, anxiety that was caused by this pandemic, still being caused by this pandemic, continues to be felt throughout our entire organization, as I know they have in yours. Next slide. Some of you may recall this front page story in the New York Times. It was featured on May the 17th. And it looked at healthcare workers in multiple states across the country who were grappling with growing signs of depression, PTSD, and burnout from the stress of caring for patients and saving lives amid the pandemic. And the Times reporter who was doing this story came to us, and we had an opportunity to share our story and some of our success in meeting the needs of our caregivers during this critical time. The photo you see here is one of our nurses at Christiana Hospital in Newark, Delaware. She's lying back in a massage chair that's in one of our Oasis rooms. These are sanctuaries, safe spaces that provide a means for our caregivers to pause the stress, take a break, to care for and heal themselves when they're having a difficult, emotionally challenging day. The Oasis rooms are just one example of the many ways that our Center for Work-Life Wellbeing supports our caregivers. So how did we get here? And certainly I was so grateful that we had a Center for Work-Life Wellbeing as we went head first into COVID. One of those decisions that got made years ago that turned out to be really important. And it exists today really because of Dr. Heather Farley, who in 2013 came to me when I was still the chief medical officer and talked about this sort of growing problem of stress and burnout in healthcare. And she asked me, could she spend some of her time really sort of developing a program, and was there funding that I could provide to actually make that happen? And I do think as one of the responsibilities we have as presidents and CEOs of our organizations is we can make this a priority, and we can resource it and create programming and support our leaders who are invested in making a difference. And Dr. Farley led that work. We stood the center up in 2015. And we started with a focus on physicians, but very quickly realized that the center needed to meet the needs of all of our caregivers across the entire enterprise. And it is now the Center for Work-Life Wellbeing. It includes psychologists, researchers, clinicians, peer supporters, and it's all about helping our workers thrive. Fundamentally built on an understanding that when we care for ourselves, we are better able to care for others. And when we're better able to care for others, that care is safer and we provide a better experience for everyone involved. So our center is wholly focused on helping caregivers flourish by fostering work-life meaning, connection, and joy, and also being there for them when they need extra support. So as I mentioned, when the pandemic hit, we were well positioned to quickly anticipate the needs of our caregivers and respond. Next slide, please. There were many ways in which we responded to support our caregivers. Certainly, we had a goal to preserve jobs and take-home pay. Like many communities around the country, families were deeply impacted by job losses. We are the largest private employer in the state of Delaware. We know the impact that we have on the economy. We wanted to make sure that our caregivers had a job and enough pay to be able to support their families. We had a while ago implemented a $15 minimum wage, and during the pandemic also implemented paid parental leave, really important for our caregivers. We also provided support in other ways, so our caregivers could feel comfortable coming to work. We prepaid and reimbursed for childcare. We offered paid time off cash outs. We prepaid hotel rooms for caregivers who were concerned about going home or needed to isolate. When we heard about some of their specific worries, we bought disposable scrubs for them. So investing in very sort of meaningful and tangible ways so that they could feel more secure coming to work. We have a food bank for our employees. We've had it for a number of years. It was very telling that in those first few months, our caregivers were going into our food bank and 3 times what they would normally do. Again, just demonstrating the impact that this had on the overall community. We have a designated COVID-19 testing center that's open 7 days a week exclusively for our caregivers. And we also established a caregiver relief fund so that we are able to continue to invest in the needs of our caregivers. We depend not only on our employed clinicians, but also private practice physicians. They are very much essential to our ability to care for all of the needs of our community. We also came up with some creative ways to contract with them so that they also could continue to deliver care in a much needed way. I think, stories often tell, really sort of tell the tale. And recently our chief critical care medicine officer was interviewed by a news reporter who asked, what's it like in the ICU these days? And Dr. Mike Benninghoff's team, as you can imagine, has been through some incredibly challenging times. They are caring for the sickest patients and focused also on protecting themselves and each other from this new disease, which seems to provide us with new opportunities for learning on a day-to-day basis. And what he wanted the reporter to know was that morale was high. He was incredibly proud of the resilience, professionalism, and optimism of his team. And he said in his mind, a key difference maker has been the Center for Work-Life Wellbeing and the staff and the peer supporters who are on his unit daily to talk with staff, listen to them, and provide support. That network of peer supporters has been a vital function of our Center for Work-Life Wellbeing throughout the pandemic. They round on units 24/7, and they create opportunities for caregivers to share honestly with someone who will listen and understand what they're going through. And the intention here is to spark joy, to kindle a meaningful conversation, and remind caregivers they have the support of colleagues who understand what they're going to and are ready to listen. And very importantly, it's also a place where we uncover unmet needs, and then we can rapidly escalate them to the appropriate level to develop solutions. And the support that our caregivers receive really comes through in the care that they provide, their ability to stay sharp and focused and keep each other safe. This is what a healthcare system based on love looks like. We know that by investing in the health and well-being of our caregivers, we're enabling them to function at the highest level through extreme challenges. In order to be truly effective, we know we need to go beyond teaching resilience. It's important, but we need to create a culture of well-being and focus on improving the efficiency of the work, reducing the friction and those things that cause people to be unhappy when they're at work. So we have built a framework at ChristianaCare, and I'm going to turn it over to Dr. Heather Farley to talk more about that framework and the work that she and her team have been doing. Dr. Farley?
Thank you, Dr. Nevin. Next slide, please. There we go. So indeed, we have been incredibly fortunate. So first, backing up, I know we missed the introduction. So I'm Dr. Heather Farley. I'm an emergency physician by training and the Chief Wellness Officer at ChristianaCare. Back up one slide, please. So we have, as Dr. Nevin mentioned, we're really fortunate to have had this robust infrastructure in place to support the well-being of our caregivers prior to COVID-19. Our investment in the well-being of our caregivers began over 5 years ago and culminated in the opening of our comprehensive Center for Work-Life Wellbeing, whose mission is to foster work-life meaning, connection, and joy. And I think that automatic, yeah, thank you. So our operational framework is depicted here, including the what of what we do, how we do it, and who we do it with. While I know I don't have time to cover the details of the framework here, I will emphasize that it has served us very well and it has enabled ChristianaCare to rapidly pivot and scale up to provide unparalleled support to our caregivers during this crisis. We were prepared for this moment and we were uniquely positioned to respond. We're here, really here, with our caregivers every step of the way, and they feel that. What we're doing is working, and we're excited to share what we've learned so that other health systems and caregivers may benefit. And so you can go to the next slide, please. Thank you. And so the strategic framework that we created for caring for our caregivers during COVID-19 specifically was built around the principles of hear me, protect me, prepare me, support me, care for me, and honor me. This may look familiar to you. It was adapted from a recent JAMA article that was co-authored by Dr. Shanafelt, Rip, and Trockel, and we thank them for that really valuable contribution to the field. And so next slide, please. The first component of that is hear me. And as part of that, the cornerstone of our approach was rounding. We conducted intensive in-person rounding on frontline healthcare providers during all shifts, with a heavy emphasis on the COVID units, the emergency departments, and the areas supporting those units. And we paired that with virtual weekly rounding on leaders in those areas. And the purpose of that rounding was threefold. First, to supply basic well-being needs. You can see that cart there that we toted around with food and drinks and comfort items like ear protectors, lip balm, and hand lotion, trying to make it a little bit more comfortable to wear all this equipment that we've got to wear. But it's really less about what's on the cart. The cart is really an entree into a deeper, more meaningful conversation, as Dr. Nevin mentioned. And consistent with disaster mental health practices, we're not waiting for people to raise their hand and say they need help or to request to access resources. We're proactively reaching out so that we're providing in the moment support, finding out how people are really doing and supporting them real time. And then serving as a direct conduit for more intensive mental health services or peer support if that's what our caregivers need. And finally, that rounding has helped us to elicit concerns and unmet needs. And that's where that first component of the hear me approach comes in. By rounding and asking our caregivers what they need, we're able to identify concerns that require escalation to either local or system level leaders. And that has led to just countless system level changes that Dr. Nevin mentioned, preparing of childcare, transparency efforts, creating a COVID dashboard and town halls, creating that caregiver relief fund, providing hotel accommodations, just to mention a few. Next slide, please. The second component there is protect me, and that means protect me and my family. And as you can imagine, a huge component of that was procuring adequate PPE for our caregivers. And we entered into really creative partnerships with our community and with industry to ensure that our caregivers had adequate PPE. We also created FAQs around how our caregivers can keep their home and family safe. We provided free hotel accommodations. And we also heard, as Dr. Nevin mentioned, that caregivers were going home in the same scrubs, undressing in their garages or sometimes even in their driveways, and were washing their soiled scrubs in the same washing machine as their kids' clothes, and that was incredibly distressing to them. So we created disposable scrub service and scrub changing areas that you can see here. And finally, we created reassignment options for caregivers with underlying medical conditions, pregnancy, or other special considerations. Next slide, please. On the prepare me side, a big component of this was preparing our caregivers for how to do their jobs, and particularly around PPE. So how to use that PPE once we've got it. So we created multiple education and training modalities. One of the really key components here was at the elbow training for our caregivers around the clock on the units of how to appropriately don and doff, and pairing that with just-in-time resources of videos of how to don and doff in different situations. We also created robust training for caregivers who were redeployed to COVID units or other areas. And we developed care standardization, evaluation and treatment protocols, as well as code status determination assistance for COVID patients, with the intent of heading off some of that feeling of practicing medicine on the fly and some of those attendant ethical dilemmas. We also recognized that this is a tough time for our frontline caregivers, and it's also a really tough time to be a leader. And so we created several resources to help support our leaders so that they can better support our caregivers, including quick tips and training on supporting team well-being during COVID-19, and importantly, a leadership discussion forum. This was a protected space for our leaders to share their experiences, exchange ideas, and take away successful strategies for leading during this crisis and challenging times. And we got really great feedback on that from our leaders, that they found that incredibly valuable. Next slide, please. Support me. We also recognized that it was important for us to collate all of these support resources into an easy to access central location. And that's what you see displayed here as our front page of our website. And that includes collating all of the ways that we're supporting their physical needs with access to food, provision of multiple free virtual exercise resources, how to find those oasis rooms that Dr. Nevin mentioned, and access to sleep hygiene resources. where to get all of those financial support resources, the cash out PTO, the hazard pay, the food pantry, how to get the family support resources that were available, how to access that prepaid childcare, elder care, and pet care resources. And then a huge component was collating all of the mental health resources that were available, including the 24/7 mental health support from our EAP services, the peer support program, how we've created an end of shift checklist for our caregivers to help them transition out of the clinical environment and home, which we posted at swipe stations as well on this as the central resource. Also collated the mindfulness resources and FAQs on working remotely or while quarantined. And finally, we heard that our caregivers were constantly bombarded by negative and anxiety-producing stimuli. And so they were craving a source of hope and positivity. So we created a daily opt-in text message system where they could receive something inspirational or self-care tips, and that's been really well received as well. Next slide, please. And care for me. That component of the framework is always important, but especially when we're talking about our caregivers who are exposed to COVID-19 or infected with COVID-19. And when that happens, it starts with providing just-in-time resources for our leaders so that when they become aware that a team member tests positive, they know how to communicate compassionately and effectively with that caregiver and with the team. And they know how to access the support resources that are available. And those support resources include one-on-one peer support, 24/7 mental health support for COVID-positive caregivers, and group support for teams who have a COVID-positive caregiver. Next slide, please. And I'd like to share a little bit of data around our peer support program in particular. What I've heard from many organizations around the country is that they're offering support resources that they're not being used. And that's incredibly frustrating for people who have really great intentions of trying to support healthcare providers through a traumatic experience. But we experienced quite the opposite. We actually had a 3-fold increase in individual peer support encounters and a 10-fold increase in group support requests during the acute phase of the pandemic versus baseline. And that's for an already well-utilized program. And I think this really speaks to the importance of having a robust system in place that's hardwired and that's seen as a natural go-to during times of crisis or distress, and to the importance of proactively reaching out to offer support, which we did through rounding. We have a culture where we've truly decreased the barriers to help-seeking behavior, and we're incredibly proud of that. Next slide, please. And finally, honor me. The expressions of gratitude that were pouring in spontaneously from the community were overwhelming and heartwarming. And it was important for us to facilitate those expressions of gratitude so they made it to our frontline caregivers. And so the children's artwork, the messages from volunteers and messages from other community members, we collated those and displayed them both virtually as well as in the entrances to our health system. We facilitated the distribution of meals and donations from the community, and as Dr. Nevin mentioned, stood up the Caregiver Relief Fund that helps to meet those unanticipated financial hardships for our caregivers, and raised over $500,000 for that effort. In addition to the gratitude from the community, it was also important for us to show gratitude for each other. So we had a Healthcare Heroes social media push with our caregivers taking selfies that we posted on social media. And we particularly paid attention to highlighting some of the unsung heroes of this pandemic, such as our environmental services colleagues. And we purposely created opportunities for our senior leaders to express in person their genuine gratitude to our caregivers, to recognize their sacrifice, their dedication, and their love for our community while working under some unimaginable conditions. And finally, around this honor me piece, another way to honor the work of our caregivers is to celebrate wins, to help them reconnect with the meaning of why they do what they do. And so we created what we are calling our Code Blossom. And upon discharge of a COVID patient, we call a Code Blossom overhead, and caregivers, you can see a picture of that on the upper right-hand screen of the slide. And our caregivers line the hallways and celebrate that discharge. And yes, it's about celebrating the patient's recovery, but it's just as much about the caregivers, because when they're able to see, when we're able to reconnect with the why, to watch one of our neighbors return home to their family and know that our efforts made that happen, that makes it all worth it, all of the stress and the donning and the doffing. And so it's really important to create those moments. Next slide, please. And so how have we been doing? What's been working? We know that, as this quote demonstrates, the solidarity of a group provides the strongest protection against terror and despair, and the strongest antidote to traumatic experience. And we're seeing evidence of our caregivers tapping into their collective strength to get through this together. We're inspired by one another and by the dedication and love we demonstrate to each other and to our community. I think this spirit is captured poignantly in a social media post that I saw from an emergency physician back in early March of 2020. And I'm going to read that to you now. And I ask you to kind of think back to where we were then, to that mounting fear and uncertainty that we were experiencing just as the pandemic started to ramp up. And so she posted, "I'm scared too. I'm scared that when I go to work in the emergency department and start seeing the wave of patients that are coming in with this virus, I won't be able to help some of them. That I'll have to make decisions who will get a ventilator and who won't. That my own health and safety will be compromised because I won't have the right equipment to protect myself. But guess what? I'm still going to go to work. I'm still going to do the job that I spent 11 years, $300,000 in my youth training to do, because it's my duty as an emergency physician to use my skills and do what I can in a time of crisis. Please support us because we're about to go to war for America with COVID-19. And that spirit, that is why the work we do to support our caregivers is so essential. As we stand shoulder to shoulder with our caregivers, they need to know that we're here, really here with them, no matter how bad it gets or how long it lasts. And I hope that every clinician can feel that, no matter where they work. Thank you.
Thank you very much, Dr. Nevin and Dr. Farley. And again, my apologies for the technical problem. I was not able to introduce the two of you. And so if you would allow me, I'm going to do a post-presentation introduction, and then we're going to move on to the presentation by our colleagues from Emory. So Dr. Nevin, I think I was saying that you actually joined ChristianaCare back in 2002 when you were hired to be the chair of the Department of Family and Community Medicine. And so you're, of course, well known for your vision and involvement in developing ChristianaCare and looking at how we create value-based care. The one thing I wanted to mention that I picked up in your bio is really your commitment to your community, and I think that came through your presentation. You received the Humanitarian Award from the Lyman House in 2018 and the Delaware's Grassroots Champion Award from the AHA in 2017. So thank you very much for your commitment to patient care as well as your community. And Dr. Farley, you mentioned you're an emergency medicine. You also received a Master's of Healthcare Delivery Science from Dartmouth College in 2018. And as you mentioned in your presentation, you were that little seed a few years ago where you went to Dr. Nevin and said, we need to do something for our clinician well-being. And of course, that's when you started developing the Care for Caregiver program. So thank you very much for sharing your experience and really demonstrating that leadership commitment is really important, but action, I think that's what I was saying earlier, action is even more important, and how you've been able to build a program and engage your clinicians, your caregivers with you. So thank you very much. We're going to move on to the next presentation by Dr. Jonathan Lewin and Dr. Sharon Pappas from Emory. Dr. Lewin is the Executive Vice President for Health Affairs at Emory University, also the Executive Director for the Woodruff Health Sciences Center, and CEO and Chairman of the Board for Emory Healthcare. He also serves as a Professor of Health Policy and Management. Dr. Lewin was trained as in chemistry, received his undergraduate degree in chemistry from Brown University and his Doctor of Medicine from Yale University. He's actually had a very prestigious and career in science, and is recognized as an international scientific leader in interventional and intraoperative MRI. In 2017, he was named by Modern Healthcare as one of the 50 most influential physicians. And he actually recently received gold medal awards from 2 professional societies for distinguished service to the field. And in 2019, the National Medical Fellowship Pioneer Award, and was elected a fellow of the National Academy of Inventors. So thank you for joining us today. Dr. Sharon Pappas is the Chief Nurse Executive for Emory Healthcare. She is also a member of the senior leadership teams for Emory Healthcare, as well as the Woodruff Health Sciences Center. She received her Bachelor of Science in Nursing from the Medical College of Georgia and a Master of Science in Nursing Administration from Georgia College, and then went on to Colorado, where she received the PhD from the University of Colorado, Denver College of Nursing. Dr. Pappas is a fellow of the American Academy of Nursing, she's the past chair of the expert panel on building health system excellence. And within Emory, she's responsible for nursing practice across the hospitals, ambulatory care, and post-acute agencies, and has been really at the forefront of the magnet designation for Emory. And I had the privilege of working with Dr. Pappas, as she was a member of the National Academy's Committee on Systems Approaches to Improve Patient Care by supporting clinician well-being. So Dr. Lewin and Dr. Pappas, we are looking forward to hearing your remarks. Thank you.
Great, thank you very much. And I want to thank the organizers of the session for the invitation. And again, following our great colleagues at Christiana is really an honor as well. As I look back at our initial successes in pivoting to COVID care back in the spring, a big reason we were able to rapidly adapt and learn is because we concentrated not only on our patients, but also on our people. We committed to making sure that our clinicians and staff were empowered, supported, honored, equipped with the tools they needed to move us forward, since the best way to care for our patients is to care for their caregivers. We understood that with 11 hospitals, over 200 ambulatory sites, and 26,000 people, along with our close linkage to a large research university, our normal processes were going to be insufficient when it came to dealing with this type of an event. We needed to develop a nimble, adaptive, and learning decision-making structure. Well, while we realize now that we're not managing an incident, but rather facilitating a long journey, we quickly implemented an incident command center to address preparedness, response, and recovery, based in part on some of the lessons we learned when we dealt with Ebola in 2014. If I could have the next slide, please. This is the structure of our incident command process. And again, it starts off with a team of 6 executives who are the incident commanders, one might say, which include myself, Dr. Pappas as our chief nurse executive, our chief medical and quality officer, our chief operating officer, and our physician group president and hospital group presidents. The 6 of us, which we creatively ended up getting called Team 6, ended up putting together a series of 17 work groups, which you see there on the slide. They went everywhere, everything from supply chain, HR, ambulatory operations, communications, government affairs, surgery, critical care, emergency medicine, data analytics. Really ran the gamut of people who would have a hands-on frontline or back office impact on COVID care. In addition, we included the operating units, again, for all of our hospitals and our ambulatory centers. the breadth of the leadership model is really built on the breadth of expert and stakeholder representation in these groups. These were interdisciplinary, strong clinician engagement, included again all of our operating units, and they were technology enabled with socially distanced meetings through Zoom or Microsoft Teams. It was very data driven. We created broadly available dashboards for things like supply chain, medical equipment availability, census, testing, surgical capacity, ED. And importantly, very early, we developed an ethics triage committee so that should we need to ration care, our frontline caregivers would not be stuck making these decisions without tremendous support. So the success of this structure was built on leadership, collaboration, and very deliberate and very abundant communication. Next slide. Two of the interdisciplinary groups that were most central to our outcome were our care model and clinical operations work groups, which were really central in a very interdisciplinary, interprofessional, and consensus-driven way to all of the basic decisions that touched our patients. Next slide. Well, the collaboration structure was built on a number of meetings each day. And these included, these started off with Empower meetings. I'll talk about Empower next. So I'll leave that with just to say, it really covered the whole system, both non-COVID and COVID, 15 minutes before we started our COVID-directed meetings. We then went into an Incident Command Center daily huddle meeting. And this included all of the work group leads of these 17 work groups, the team 6, all 6 of the team 6 leaders. And it was run by an incident commander, one of the team 6, who had the week's assignment to run the entire incident command structure for that week. These meetings included assessment for situational awareness and stakeholder needs for the day-to-day operations for that day in the morning. We triaged issues, developed action plans with the work groups and stakeholder input. And again, lots of communication and back and forth with the Team 6 leaders. We then went into another hour of just the Team 6, just the 6 leaderships, sitting and discussing how did things go that morning, where did we see issues coming up, what were internal and external communication needs for the day, and importantly, starting to look at how do we look out into the far future from the very beginning, how do we start looking at recovery and response. We then went into our afternoons, which included, again, work group meetings where the select of these 17 work groups would work on their day's work as a group. These were optional depending on the needs. They didn't happen every day. The others were every day, but they essentially were based on the needs that were developed in the morning meetings. And then we went into our afternoon daily huddle. And this was a bigger group. It included the same as the morning huddle. So the team 6, all the work groups leaders, all of our operating unit leaders, but also that included all of the major Emory healthcare stakeholders. That included the clinical chairs of our medical school, all of our chief operating officers, chief nurse executives, chief medical officers, and including CEOs of all of our hospitals, our physician group, ambulatory leaders. And that was really a way to take the work of the day, integrate it with the larger group, it was about 130 people, to look at collaboration across the different entities, the different operating units, and across the work groups. And then we went into our last meeting of the day, which was another hour with the 6 of us as the top leadership, again, to look at the day that occurred and to plan the next day. It may seem like a bit of overkill when you look at the number of hours. This was 7 days a week for our first 3 months or so, although Saturdays and Sundays we cut down to either 2 or 3 hours of meetings. But it was really critical to create the community, to create the understanding, and really to create the nimbleness in decision-making. So we launched a number of operational changes with new and updated system-wide policies and procedures in a matter of days, things that would have taken us under our normal operational systems and decision-making, maybe months, maybe longer. Some of these things we could never get to consensus on. Things like mandatory masking, visitation policies, temperature screening at the doors, PPE reprocessing and supply. These were done very quickly. We rolled out our pre-procedure and pre-admission testing for all non-COVID patients, greatly grew our telehealth capacity from initially around 100 per month to about 3,000 per day. Within about 2 to 3 weeks, we developed that. A number of innovations occurred as well. We developed our own PCR testing, our own serology tests, both of which received FDA emergency use authorization very early in our journey. We actually more than doubled the state of Georgia's PCR capacity when we first got our EUA. We innovated new ways for patients to communicate in the COVID ICUs through baby monitors, with iPads, and we leveraged our academic and research differentiator by leading many of the national efforts around vaccine and treatment development. And when it came to our people, we rapidly moved most of our back office workforce to full-time remote work. We redeployed employees to new areas to help where needed, as in particular when we closed down some of our elective and non-emergent surgical and other procedure services. And we internally tested now more than 10,000 of our employees for COVID-19 with a very carefully designed return to work plan for people who were positive. We did a surveillance with more than 11,000 team members getting the serology testing that we developed. And we worked hard to connect to our people, to our purpose, connecting our people to our purpose through Zoom meetings, emails, videos, music, humor, every other means available to ensure that our people felt part of something bigger than just themselves. And we worked with the community to show the love for our healthcare team with socially distanced recognition, many hundreds of thousands of donated meals, donated PPE, and manufactured PPE from our community, along with an outpouring of appreciation from our Atlanta neighbors. Next slide, please. Well, improving lives, providing hope, putting our patients and families, our people, and our community first in all we do. When we developed this core purpose and true north at Emory Healthcare as part of our strategic planning process, we could not have predicted how crucial they would become. Many of the elements of that 5-year plan, which included investments in telehealth, systemness, clinical research, and most importantly, our people and culture, have been critical. And the strategies we developed before the pandemic for moving forward in good times are equally powerful in these tough times. So our COVID-19 outcomes, including strong ventilator survival rates, PPE stock, clinical research breakthroughs, and more, are the returns on these investments for the 5,500 COVID patients we've admitted at our hospitals to date. The most important element of our foundational work and the component that I believe contributed most to success in our journey was our development of our lean operating system, which we call Empower. And it's not just a set of process improvement tools, again, not just the lean tool set, but it's a culture of inclusion and engagement primarily. And Empower relies on a tiered huddle structure, which is critical to ensure top to bottom, clear and succinct two-way communication. Members of the medical staff, operations staff, executive leadership are all involved in the hospital's huddle and communication structure. We start off every morning between 7 and 8 with frontline 15-minute huddles on all of our units. We're well on our way to 900 huddles a day. That then rolls up to a tier 2 huddle, a tier 3 huddle at the operating unit level, and so forth, until it gets up to a tier 5 huddle every day at 9:45 in my office suite, in the C-suite, of course, now by Zoom, or actually Microsoft Teams. But those huddles get the information from the front lines to the C-suite every day, not just about COVID, but about everything that's impacting our frontline people. So it engages and tells the front line that we are listening to them and we are taking care of all of the issues they have as quickly as possible. Training's another part of Empower. We've trained over 2,000 leaders so far to date. And the level of engagement of our people from the front lines to the C-suite and the clarity of communication and purpose that we enjoy are directly linked to the power of Empower across our system. So I'd like to ask now Dr. Pappas to continue to talk a little bit about the interprofessional work that we're doing. Sharon?
Thank you, John. Appreciate you sharing all that. And so what I'd like to do is bring to life for you a little bit of the work that John just described and what it looked like during the height and continues on during the pandemic. So if you'll turn to the next slide, please. One of the things that we recognized early on, because we have over 300 critical care beds across all of the Emory hospitals, and at our peak of our pandemic, about a third of those beds were full with COVID positive patients. And so we were having to do a lot of things that allowed us to pivot, but moving patients between hospitals to make sure we provided adequate care. And so one of the features of us doing a lot of this also was very dependent on leadership, and not just a person in place, but the right person, because we felt like the ability to pivot wasn't just about changing direction. It was about keeping one foot soundly grounded in our purpose, which is improving lives and providing hope. And for COVID, it was about providing excellent patient care and keeping each other and our patients safe. And so keeping one foot grounded in that purpose allowed us to pivot around that foot and move in any direction that we needed to move. And so our leaders were often out and about, and the questions that they asked were, how are you? And how is your team? Because most people, when you say, how are you? They say, oh, I'm doing okay. But when you ask about their team, you get a little more colorful information that might also reflect on how they're doing as a clinician as well. So that leader interaction was incredibly important. I recall many days when John would be leading our huddle and he would encourage all of us to turn on our cameras on Zoom so that we could actually see each other and be able to see the faces of the people that we were partners with and doing work with, so that it kept that human touch as a very important part of the leadership work that we were doing. And it also made sure that not just in the late stages, but early on, we were starting to measure and do some projects around, people who were seeking additional help when they needed it. We were also launched a burnout survey with the director of our critical care unit during the month of July, just so that we could get some follow-up data to a burnout survey that we did about 3 years ago, and make sure we are measuring for each clinician by each one of our ICUs so that we can actually understand better what some of the basic needs were. The second thing I'd like to talk about is decision-making. And you heard Pascal say earlier that we have several magnet hospitals across Emory Healthcare. And so you might suspect that our system of professional governance was very strong. And so we got to a few forks in the road where we were making decisions about PPE reuse, making decisions about placing the IV pumps outside the patient room in critical care, and other critical decisions that we wanted to make. And so we thought, let's use our professional governance structure. And we have an Emory Healthcare System Practice Council, which is made up of all the chairs of the hospital and the clinic councils. And so we pulled them together and we got feedback from them about how they felt about reusing PPE and reprocessing masks and gowns. And with that feedback, we were able to make really better decisions about what we did. But here's the most remarkable thing about gathering that group together. We thought it was going to be mostly nurses. But when we got the group together, we found that there were respiratory therapists, physical therapists. There were some physicians who actually joined that call because they were on that front line and wanted to have input and access to some of that decision making as well. So we realized how important it was. We also had to take some steps to actually change our work, because we were going through a lot of PPE at a fast rate. Excuse me. And so we developed this concept called warm zones, where we actually created the ability of clinical nurses to move between patient rooms and also to not have to remove their PPE to get something outside of the room when it was passed from a cold zone to a warm zone. And so I think that allowed innovation at the front line. I didn't think of that. It was the front line that actually came up with that concept. And quickly, through the structure that John described, we replicated it across the entire system. The third thing I want to talk about is some accountability, professionalism, and advancing science. As John mentioned, we were pretty proud of our low mortality rate for our ICU patients, and now we're realizing not just ICU, but all of our COVID admissions, we had a very low mortality rate. And so, as you might guess, in an academic medical center, we had several physicians who were, and researchers who were working fast to get some of our work into publication. The director of our critical care team came to me and he said, you know what, I'm realizing that our ability to keep nurse staffing at the appropriate levels played a big role in our critical care survivability. And so I want to include some nurse scientists in the publication as co-authors, which he did. And so that interprofessional effort really spoke a lot to the amount of recognition that we had that it was a team, as you can see here in this slide. So please change to the next slide for me. So what I want to say is that, you know, we had a lot of opportunities to improve lives and provide hope. And one of the other things that we took some steps to do was we included our patient family advisors, which is a vibrant group that loves to talk to us about how to make healthcare better. And so we pulled them together as we were moving or pivoting from a system of limiting visitation to a system of creating a concept called care partners, where we had purposeful partners that were allowed in, screened as everyone else, but could attend a patient who needed extra assistance while they were in the hospital. And this was a big step because the work of those patient family advisors really helped us to know the importance of the care partner, but also to do it in a way that was very patient-centered. You can see here in this picture is an example of one of our patients when they were going home. Like Christiana, we celebrated that all the time. One of our hospitals had a concept called Code Happy, and they played the music Happy when the patients went home. And it was so rewarding for our clinicians to see the patient reconnect with their loved ones at the other end of this lobby. One of our other hospitals had a Code Rocky, where the patients would come out of the elevator doing like Rocky, because they had survived and they were going home. And we also tuned into a lot of our very special talent across Emory Healthcare and added music, as you can see there in one of the pictures, that contributed to the clinician well-being in many of our units. But the last thing I want to share with you is the importance of community and connection. Because within Emory Healthcare, we also have a skilled nursing facility. And we learned that we had a patient there, Miss Sowell, who was over 100 years old. And she was very proud of the fact that when she was a baby, she had survived the Spanish flu. And now, 100 years later, she had survived COVID. And she was a nurse. And so I put on my PPE and I went down there and I spent a half an hour with her one afternoon, just talking with her about her experience of surviving 2 pandemics, and now was healthy and ready to live out her life at our skilled nursing facility. Her background was as a master's prepared nurse in mental health, and she worked in Tennessee and practiced in an organization there pretty much autonomously, which was pretty exciting for that era. And I asked her, I said, what would you have me tell our clinicians, Miss Sowell? And she said, first, I want you to tell this to your nurses. I want you to tell them to always be a nurse, not try to be someone else, because that's really important. She said, the second thing I would say is to all of your clinicians, listen to your patients and listen to each other, because it's that connection that fills your soul. And I just felt like her message was so important. We shared that across our incident command when we had those meetings. And while they look very, very much structurally in command, they were so much about personal connection and community every day that we met, because we included a thought for a day, we included music, and we included a lot of our own personal stories in those day-to-day meetings. So I'm proud to share with you, with John, our Emory experience. We're still learning and have a lot to learn, but we're very proud of what we've been able to accomplish and looking forward to where this journey takes us next. So with that, Dr. Carry-On, I'll hand it back to you.
Thank you very much to all of you for sharing your experience in going through the height of the crisis and now what's becoming a pandemic and a continued pandemic. And so actually, so before I ask you the first question, I just wanted to tell our audience that if you have questions, please put them in the question and answer, and I picked up some of them already. But as the facilitator of the session, I'd like to take the privilege to ask the first question to our four presenters. So when we think about clinician burnout and well-being, you know, we often think about where the way it was before, and then back in March, and then it just continues. And so sometimes I think about where we were already in an environment that had many aspects that we needed to figure out that were just not well designed. And then the pandemic comes on top of it. And it's not just a short-term crisis, it goes on and on and on. So then it becomes chronic. So I'm actually interested in hearing from you. You've talked about how you use your strategy and your infrastructure before the pandemic to help you transition. But, you know, it's just going to continue. We got to figure out how to do things differently. So I'm interested in hearing from you about how you're thinking about that, actually maybe that new phase that we're getting in where we are no longer in the acute phase, it's chronic and it's acute. So please share thoughts that you have about how to address clinician well-being in that maybe post-crisis and chronic phase of the pandemic.
Yeah, I'm happy to make a few comments and then turn it over. You know, when we started in March, it felt like a sprint, and I had to keep telling people this is going to be a marathon, you know, so let's get ready for it. And I think now I realize it's the Ironman version of the triathlon. And I think your point, Pascal, is really well taken, because, you know, that first phase felt very much like the swimming part. And now we're on the bike with COVID, and we have to learn how to adapt and live in a very different world. You know, I think it would be a, you know, almost a tragedy if we don't take all of those early learnings from the first few months and think about how we want to put the pieces back together so that we are creating a very different system as we think about our future. In many ways, that's the opportunity that we have. We took so many things down. We learned so much. We learned a lot about our caregivers. We also learned a lot about our community, you know, the disparities that exist, the equity issues that really came to light as a result of this. And so, you know, what we've talked about is, as we think about our future, how do we come back in a way? How do we sort of get to that next stage without recreating what we had in February, but actually coming back so that we can be more efficient, that some of those very important pieces that you talked about in your opening that cause friction, those processes, those work systems, you know, this is our opportunity to say, we're going to design that work differently, and we can be more efficient. I loved the phrasing of nothing with me without me that I'm very familiar with in the work of patient and family-centered care, but it works so well, I think, for our clinicians. And so I really see that as our opportunity. Is it's in that design. We can design differently to solve some of the problems that have sort of perplexed us for years, frankly.
Yeah, yes. Thank you, Jan. I agree completely. And just to add a little bit to that, there's a model of psychological phases in crisis and disaster. Originally, it was published back in 2000, and Jimmy Potash at Hopkins brushed it off, and I became aware of it through my old colleague Jimmy. And it's interesting because the heroic phase, which is what we were all in March and early April, is actually easier. You know, when you're at that heroic phase, there's sort of the honeymoon where you finally have things under control. You're being recognized as heroes. There, you know, in Atlanta, there were balcony parades where people were banging pots and pans when our Midtown Hospital folks got off work and were heading, you know, in their cars through the corridor. But then you get into the sort of the trough, the valley of disillusionment. And that's the tough part. And that's where, you know, we got into June, July, the community started to forget about the frontline people. And we had numbers that were, again, 70% higher than our April peak. We had a second peak, much worse than the first, and nobody was paying attention. And that's when I think the health, the well-being, the wellness, and the resilience and the risk of burnout are the highest. And that's when, into some way, our incident command, while that March, April, we were making decisions, changing things, opening up ICU beds, really a ton of operational work. I would say that through the July, August peak, it almost more was a place of community for the leadership to get together, to talk about what were their problems of the day, to get thoughts about solutions, sort of group thoughts about solutions. But a lot of it was really knowing that you're not in it alone. And I think that was one of the more important pieces, as you talked about leadership well-being in yours. And I think Sharon would agree, we still meet 2 hours a day with our Team 6. We've cut down our other incident command a little bit. We actually just recently went from 10 hours a week to 8 hours a week for our Team 6, but nobody wants to give it up because it's the way that we can actually work together as a leadership team and keep ourselves tremendously moving forward.
Mm-hmm. And I would have one more thing in that I have become aware that resilience isn't something that sits out here, that it really does need to be designed in our work systems so that it's integrated. And that has required me to rethink kind of the skill set and the talent of our leaders and their ability to see resilience within instead of something you go do. And so, you know, to me, that is another really important step. And John has been a great support in augmenting some of our structures with the type of talent that'll help us to do that on a larger scale within our leader development, as also within just some expertise that we needed within Emory Healthcare. So I think that's another big learning for me, that it has to be woven in for that community and that collaboration to continue.
Thank you. Heather?
From my perspective, you know, building on what Dr. Lewin was talking about with that model of you know, mental health over time during disasters, and you know, recognizing that when we've got our head down in the acute phase and you know, working on adrenaline, and when that wears off and it's now, this isn't going away, these are some of the times now that people are beginning to have the time and the space to reflect on what they've been experiencing. And, you know, so as much as some of the focus from the public has gone away from our frontline healthcare workers, these are the times that we as health systems really need to keep the foot on the gas in terms of how we're supporting our clinicians, because this is when it really does make a continued difference, whether folks are developing, they're definitely at higher risk for PTSD, anxiety, depression, substance abuse, and how can we help support them through that, and you know, help us get to a point where both as individuals and as organizations that we're experiencing post-traumatic growth, how can we learn and grow and find meaning in what we've been experiencing. And I think that in addition to making sure that we're checking on people proactively and have those robust support resources available, I think as we are navigating our way through a new healthcare environment. And, we're trying to be nimble and innovative and also react to some of the financial pressures that many of us are experiencing, knowing what the mental bandwidth of our frontline caregivers are as well, and our leaders. So we need to change. We need to try new things, and we need to improve how we're doing things, and we need to do that with an understanding of change is change, and that people are their reserves are so low right now in many cases, and how much energy and bandwidth do they have to implement that change, to absorb change, and how can we create, and I don't know the answer of exactly how to do this, but how can we create, to the best of our ability, some foundation, some stability for them as we progress through this together.
So thank you, Heather. So I'm actually going to start with you, and then maybe go in the reverse order, then with Dr. Lewin, Dr. Pappas, and then Dr. Nevin. But so my question with you, and then for our other participants, is actually combining a couple of questions that came through the Q&A, and thinking about the fatigue, I think, that you were talking about. And we've also talked a lot about well-being and burnout of clinicians and other healthcare workers at the sharp end. And we've talked about leadership and the importance of leaders at all levels. But what about the well-being of those leaders at all levels? And so how do we think about it? How do we help them? So thoughts about that, and I think that's going to be our the last part of our conversation. So Heather, go ahead.
That is a fantastic question. I think having empathy on all sides is so important, and I think our leaders strive all the time to have empathy for our caregivers, for our frontline caregivers. But that flip side is true, and a lot of my work is oftentimes helping our frontline caregivers to understand what it's like to be a leader right now too, and to have one of the practices that we've woven into our daily management system is around humble inquiry and psychological safety. And so teaching our caregivers how to use appreciative inquiry, humble inquiry of understanding why things are the way they are, why are those pebbles in their shoes existing, and why might someone be making this decision, or so really helping and grounding ourselves in our values that help us to have those interactions in a productive manner also. So I think really just coming together as human beings helps us to support our leaders as well. And then I think creating those forums where our leaders can have a safe space to normalize what they're experiencing. It is an incredibly difficult time to be a leader. And I think also not expecting our leaders to be superhuman. And I've seen some real courage on the part of our leaders in our organization to be transparent around what they're experiencing and their anxieties, but finding that balance between empathizing with the experiences of our caregivers, and yet projecting strength and confidence, but normalizing what they're going through. And I think that the expressing that vulnerability on the part of our leaders, and it makes them more human, and makes it more okay for the rest of our caregivers to recognize their own struggle and know that we are all human, and this is a very difficult time for everyone, and let's connect with our common humanity so that we can kind of get through this together.
Thank you, Heather. John?
Sure. Well, reverse order is Sharon. I don't want to jump in line, but
you go ahead. Okay,
I will do that. No, I agree. I think, as Heather said, I agree with everything that Heather has just said. For us, there are two things. One is Sharon mentioned, how are you? How are your team? And I when I have one-on-ones, or it's always, how are you? How is your family? How are you doing? Mm-hmm. And sort of just asking them, and really caring, authentically care, because I really do care about how they're doing. And I think showing that empathy, sort of, and to be honest, that's the most exhausting part of being a leader, is continually turning on that empathy spigot full stream, which is what we need right now. But at any rate, I think that, and then the sense of community, as I said, making sure that they know they're not alone, creating those groups and making sure they come together with people at similar levels of responsibility. And then the last thing I'll mention is an interesting financial mitigation step we took. We lost $350 million of revenue, drop in revenue in 6 weeks, in the second 2 weeks of March and April, which thankfully we are digging out of. But one of the things we did is, we had furloughs, and we had for our leadership either a week of unpaid furlough or the equivalent salary drop, for in a 6 week, or I guess it was about a 10-week period. So 1 out of 10 weeks, about a 10%, 9% salary drop. And all but 2, while everyone sort of said, I'm not sure I could really disconnect, because the rules around furlough is no texts, no email, no phone calls, or else you run into these, labor law issues. So it's truly cut off. All but 2 of our top leadership decided to go with a furlough. And when they came back, they said, you know what, having a week when I couldn't even talk to anyone about this was one of the most healing things that's happened to me. One of our hospital group presidents said, first night I didn't dream about COVID after about 3 nights since this started 3-4 months ago. So I think that was also just the time away, the respite is important.
Mm-hmm. And the only thing I would add to that, I agree with Heather and John. I think that's right on. But we did a lot of recognition. When you looked at our huddled structure, we ran the slide deck that was projected on Zoom. And within that slide deck, we always tried to have a story from the bedside or something that was happening out there that gave us a platform for recognition and saying thank you to our people. And I just think that was so incredibly important because it said to them, we know you're out there, we know you're doing great things, even though we don't see you on your unit. But I also tried, every time that a big story would come up on the huddles, I would always try to follow that up with an email to the CNO and to the leader of that unit, and just say thank you. This is incredible work you're doing. So I just think that recognition of them and also recognition that you're doing great work that's making a difference was another way to strengthen that community and make sure everybody knew we were all in this together and that nobody was alone. So that would be the only thing I'd add.
Thank you, Sharon. Janice.
Great comments, and certainly I think in both organizations we continue to take a very similar approach. I'll just speak a little differently, sort of about my own personal well-being. I as the CEO, we spend all of our time worrying and caring and planning for and supporting all of our people. And it sort of dawned on me early on that if I didn't take care of myself, I wasn't going to be able to do my job well and care for all the people who really needed me to be the best leader I could be in that moment. And I love to exercise. I do yoga for mindfulness, and all of those places closed. Mm-hmm. And so it was my daily walks. It was the Peloton, where the coaches tell you you're always doing a great job no matter what's going on. And I taught myself how to meditate. And, I'm a big, and it's something we actually offered for all of our caregivers, and we gave them access to a mindfulness app. But, I do think as leaders, as we talk about well-being, we have to also be willing to be vulnerable personally and invest in our own well-being.
Well, thank you very much to all 4 of you. I think that what you shared with us has been really amazing, and thank you for your insights and for telling us also about some challenges that that you've encountered, that you're trying to deal with, and the path moving forward. I think my last comment before we go to the break, and I think I've heard that from several of you, is we're all in it together. And so thank you for allowing me, a non-clinician and engineer, to be part of this conversation. And thank you to all four of you for helping us figure out how to really tackle that deep problem of clinician well-being. So we're going to be taking a break, I think of 10 minutes, and we will reconvene with our next session, 3 on leveraging data to impact the design of systems for clinician well-being. Thank you.
Thank you.